Hello and welcome to this video about UTIs in pediatric patients. So UTIs are common in pediatric patients, in kids, and they can also be common secondarily due to an underlying anatomical abnormality. So let's start. Remember, young infants typically present with features with just fever. Young infants who have a UTI typically present with just fever. Whereas older infants or older children, they will have symptoms similar to adults, such as a high fever, flank pain, back pain, abdominal pain, dysuria as well in frequency. So if it's a young infant who have non-specific UTI symptoms, they will just have irritability, fever and vomiting. Remember, E. coli is the most common microorganism in children of all ages. And the most important thing we're thinking of E. coli is, of UTI, is a positive urinary leukocyte esterase, positive urinary nitrite, pyuria, which just means a high white cell count in the urine, and bacteriuria. So we're kind of checking for four things in the urine analysis. So we're looking for positive leukocyte esterase, then we're always looking for positive nitrites, then we're looking for pyuria, which is simply a high white blood cell count. So your investigations for a UTI is step 1, urinalysis, step 2, do a urine culture and sensitivity. Your urinalysis initially will just show leukocytes, glucose, pyuria, high white cell count, whether or not there's an RBC cast or a white blood cell cast, those kinds of things, or RBCs. But the urine culture and sensitivity will determine which uropathogenic agent, which bacterial agent is responsible. So let me ask you a question. When we start to treat these patients with UTI, are we going to wait before we give the treatment until step 2? No, you always start with broad spectrum antibiotics here, broad spec antibiotics, and then you narrow based on the results of the culture and sensitivity. So UTIs are very simple. UTIs in young infants present with simply fever, and UTIs in older children present with more familiar symptoms like dysuria, pain while urinating, high temperature, which is a fever, and then frequency and flank pain as well, for example. Okay. The other things that I want to tell you is that we start with urinalysis, which we're looking for pyuria, which is a high white blood cell count. After that, we'll move on to a urine culture and sensitivity. Okay, and we always start with broad spectrum antibiotic treatment because we want to give empiric treatment as soon as we can. The point of giving empiric treatment as soon as we can is because delaying an empiric antibiotic treatment will cause renal scarring, can cause renal scarring. The other thing I want to tell you is that in any infant with recurrent UTIs, okay, here is my attempt at drawing a baby. He's got his little pacifier. Any infant with febrile UTI, right? And then let's say at this point you give them antibiotics, but the fever still spikes, the fever still stays high. At that point, you should consider underlying anatomic abnormality. At that point, we will consider an underlying anatomic anomaly because his fever is not being solved, and otherwise we will also consider specifically a vesicoureteral reflux. That's both in the case of a high fever or in the case of recurrent UTIs. Recurrent UTIs in children with recurrent episodes of febrile children are most likely due to an underlying abnormality anatomically. A 7-year-old girl presents with urinary urgency, frequency, suprapubic pain, no flank pain, but UA shows many leukocytes, 2 to 5 red blood cells, and no proteins or casts. The next step here would be urine culture. Older children have more localized UTI symptoms such as fever, dysuria, and abdominal pain. The definitive diagnosis requires a positive urine culture from a specimen obtained with a sterile technique. 6 months, so we already established the difference between a young infant and an older child. A 6-month-old infant presents to ER and he is found to have a UTI. He's hospitalized, given IV antibiotics, but remains febrile. What did I say? You gave the antibiotics at this point and their fever continued to spike. In that case, we will consider this patient to have an underlying anatomic anomaly. So think pyelonephritis secondary to an anatomic abnormality. The next step would be ultrasound. Whenever we're considering an anatomic anomaly, we're going to immediately do an ultrasound. In infants, all UTIs are presumed to involve the kidneys and therefore should be treated with IV antibiotics. If an infant remains febrile or they have a recurrent UTI, these two are the specific conditions which I mentioned over here, that may indicate an underlying anatomic anomaly or vesicoureteral reflux. So what is the definition of pyelonephritis? It's an infection of the urinary tract by bacterial pathogens. Now, where are they acquiring these bacterial pathogens from? So the genital system is very close to the gut system, right? So it's going to be fecal or genital bacteria, which may cause the UTI. The most common in patients without an underlying anatomical anomaly is E. coli. This is absence of underlying anatomical anomaly. So that is E. coli, which is then followed by Klebsiella proteus and Enterococcus. So Enterococcus and Proteus are more common in patients who have no underlying anatomic anomaly. However, the most common ever pathogen is E. coli. Staph epidermidis in sexually active females. UTIs are more common in males in the first year of life. So initially, males more than females at birth. But as soon as the age increases, as the age rises and the children get older, females are more likely than males to have UTIs, and that is because they have a shorter urethra, so it's anatomically, the bacteria are more likely to climb up when it's a shorter distance to travel. The risk factors for UTIs: having a female gender, an uncircumcised male, vesicoureteral reflux. So what is this? Vesicoureteral reflux is kind of like, here's the bladder. Let's say here are the ureters and here is the kidney. So vesicoureteral reflux, essentially, once the urine has gone from the ureters into the bladder should kind of contract, and as it contracts, it closes off this vesicoureteral junction. So normally, physiologically, what we see is the vesicoureteral junction kind of closes a little bit and it kind of tightens this space, tightens this door, blocks this door, and as the bladder contracts, let's say it moves down here, that will prevent any of that urine from going back up and refluxing. But what is this is an entire reflux. This is a reflux. This is when there is no tightening, there is no closing of that door, and from the bladder back up to the ureters travels your urine. And as it does so, it can go all the way up to the kidney and cause inflammation, and it's going to cause bacteria to accumulate. Because remember, when you are getting urine back up and you're mixing that with the already pre-existing urine that's coming down, you're going to that's just a breeding ground for bacteria. It's very, very bad, harmful. Anatomical anomalies can also cause UTIs, for example, like a duplex kidney kind of thing. Bowel and bladder dysfunction, so someone who has incontinence, holds their urine, and has urgency or frequency, they might have it. Sexual activity, because you're exposed to more bacteria. And then constipation leading to obstruction. So let's say if you have constipation and there's a stool kind of fecal stool kind of thing here, then that's going to cause kind of pressure on the bladder, leading to a little bit of obstruction and incomplete bladder emptying. A neurogenic bladder is when there's an abnormal innervation of the muscles of the bladder, and in which case the muscles of the bladder and the sphincter do not contract together, which can be caused by a meningocele or a spinal cord injury. Meningocele or spinal cord injury. So you kind of want to remember, like, okay, a girl got a UTI, but her brother, who was an uncircumcised male, got a UTI after her. Then their sister had a vesicoureteral reflux and an anatomical abnormalities with a duplex kidney, for example. But then the girl who had the shorter urethra now also had constipation and incontinence, and then she engaged in sexual activity, and then she had a spinal cord injury. So if you make a story somewhat like this, you'll be able to remember all of the risk factors for UTIs in kids. Now, the differential diagnosis for pain while urinating, because this is the common presentation in older kids, is infections, UTIs are reproductive, trauma. So what's going to cause burning pain during micturition? Sexual activity, for example, stones, some sort of urethral stricture. And systemic illness. So classification of UTIs can be a pyelonephritis, which is an infection of the kidney. Pyelonephritis, just remember it's kind of infection all the way going up to the kidneys, so it would be here. So it's going to cause, because our kidneys are towards kind of the back, and they're going to have abdominal or flank pain. They're going to have fever because the body's trying to raise the temperature and put out more white cells, raise the temperature to try and eradicate this bacteria. Malaise, nausea, vomiting, and diarrhea. Cystitis is infection of the bladder, and in this case, with infection of the bladder, the location is going to cause such a pain where they will have suprapubic tenderness, suprapubic tender pain. Pyelonephritis was pain at the back, because that's where the kidneys are, kind of. Okay, cystitis was pain in the suprapubic region, so it would be here. Okay, with dysuria, urgency, frequency, and a malodorous urine. But cystitis does not typically cause fever. That's really important to remember. Cystitis does not typically cause a fever. Then you have asymptomatic bacteriuria. This is when you have colonies of more than 50,000 ml of single bacterial organism on 2 successive cultures with no fever, no UTI symptoms, nothing. So you don't treat this unless the patient is pregnant. Okay, and patients who have just been recently hospitalized, consider methicillin-resistant Staph aureus or Pseudomonas. Now, as we're coming to the symptoms overall, clinical presentation of UTI in children of all different ages, I want you to remember 2 different categories. So UTI in a young infant versus UTI in older children. So, UTI in a young infant, will they have fever? Yes. UTI in an older child, will they have fever? Yes. But what about flank and abdominal pain? Well, will the child be able to tell you that they have flank and abdominal pain if they're 2 months? No. There's none of that, but there is flank and abdominal pain in an older person. Will the child be able to tell you whether they have pain while micturating? No. So dysuria is again common in the older child. Okay. Then urinary urgency and frequency are left. Okay. So we talked about fever, flank pain, dysuria, FFF, D, UF. FFD, UF. Fever, flank pain, dysuria, urgency, and frequency. These are the main features. Actually, you should just call it Duffy. Dysuria, urgency, frequency, flank pain, fever. I don't know what the I was for. There was no I. So fever, flank pain, dysuria, urgency, and frequency. Again, this young infant, this 3-month-old, this 6-month-old will not be able to tell you whether they have any of these things. Will you be able to see whether they have urgency and frequency? Probably not. All neonates and young infants, both of these, will only present with a fever plus non-specific findings. That might be that failure to thrive, poor feeding, vomiting, and they might have prolonged neonatal jaundice. Foul smelling urine might be something that you want to look for. and then more than 2 months will have all of those. Complications of UTI include renal scarring, because what is pyelonephritis? It's inflammation of the renal parenchyma secondary to a bacterial agent which has invaded our kidneys. So complications include renal scarring, which is loss of the renal parenchyma, hypertension, and end-stage renal disease. What we're specifically looking at in pyelonephritis on the ultrasound is we're looking for hyperechogenicity. Hyperechogenicity, and we're comparing that with nearby organ systems like the liver, parenchyma. Complications are more common with pyelonephritis, recurrent UTIs, and vesicoureteral reflux. Now let's move on to the investigations properly. So the gold standard is urine culture plus urinalysis. What are we looking for on urinalysis? There's 2 diagnostic criteria which we can use. PB, which is pyuria and bacteriuria. Pyuria and bacteriuria. PB. If the child is not toilet trained, you have 2 options, which is cath or bag. Okay, cath or bag. If it's a baby, you can't really clean the perineum, because if as soon as you do, they will just pee again. Okay, so it's kind of like you could do a catheterization, but you do not do this if you don't suspect UTI. If you're really sure that it could be a UTI, then you do a catheterization. Or you can do a suprapubic tap. Because remember, it's very hard to keep this specimen sterile, and that's the most important thing. You need a sterile specimen. So cath or bag, catheterization is more common, and then you can insert a needle into the bladder, suprapubic tap. So what's the diagnostic criteria? I said PB, didn't I? Positive peanut butter in the pyelonephritis. P is for pyuria, which is a high white blood cell count, more than 5. And B was for bacteriuria, which is a positive gram stain, for example, or the presence of more than 50,000 colonies. Pyuria must be present for diagnosis, even in patients without any fever. Why is urinary nitrite not sensitive in children who empty their bladders frequently? Why? Because that conversion from nitrates to nitrites requires 4 hours, okay? Requires 4 hours. Do you think kids wait 4 hours, or little infants or kids wait 4 hours to go to the toilet? No, they're going to the toilet very, very frequently. So it does not allow enough time for the conversion of nitrates to nitrites, okay? Though it is highly specific when it is found, most of the time it isn't found, which is what it means by not sensitive. Most of the time this test is not sensitive because it's doesn't come out positive in all of the tests that are done, the result is not found mostly, whereas it is highly positive when it does come for UTI. Leukocyte esterase should be positive. Leukocyte esterase, nitrates, remember lens. Plus or minus hematuria, which are white cell and white cell casts. Treatment, finally. Okay, it is often difficult to distinguish cystitis from pyelonephritis in children less than 2 years old or young infants, to treat them the same. Start empiric antibiotics because delaying the treatment may cause renal scarring. If it's a UTI in a young infant, most of the time, actually any time you have a young infant with a febrile illness, you need to investigate for UTI. Whenever there is a young infant with UTI, young infant with a high fever, what are you going to do? First, you're going to investigate for UTI. Second, you're going to investigate for an anatomic anomaly. Because a young infant with a UTI, most of the time, they have an anatomic anomaly. So if you work backwards, that anatomic anomaly is going to predispose to a UTI, and that's going to cause the high fever. So all infants with a febrile illness, UTI, need an ultrasound. So if it's an infant less than 2 months of age, we are going to give them 10 to 14 days of IV antibiotics. We're going to start broad spectrum, then we're going to narrow based on the cultures. Remember here, start urinalysis, broad spectrum antibiotics at the same time after you get this. Then you're going to do narrow spectrum after. Okay, so you want to give cephalosporin, cefotaxime, gentamicin if it's a neonate less than 7 days. More than 2 months old, you're going to do 7 to 14 days, 1 to 2 weeks of oral or IV antibiotics based on sensitivities in the local sensitivities in the hospital. Cephalosporin you can give amoxiclav, augmentin, or you can give trimethoprim sulfamethoxazole. But we do avoid nitrofurantoin. Why? Because it is excreted in the urine, okay? And it's not going to stay long enough in the serum, in the blood, to have a positive effect. Bladder and renal ultrasounds can identify factors predisposing to UTIs, which can include an obstruction and dilatation caused by hydronephrosis, dilation or duplication of the distal ureters, which we diagnosed on the ultrasound. So we did see a patient who had a duplex ureters, or duplex kidneys, and duplication of the distal ureters, and that was diagnosed on the ultrasound, okay? So that's how you would investigate it with ultrasound. You can check for solitary kidney and a perinephric abscess. What would be the characteristic feature of perinephric abscess? Patient with persistent high fever, which does not resolve on your persistently high fever or temperature, which does not resolve on antibiotics. So that means that there's an abscess, which causes a swinging fever. Who are we going to indicate? Which patients are we going to be indicating for ultrasound? What kind of patients would we actually indicate for ultrasound investigation? It's going to be children with two or more febrile UTIs. Children less than 2 years old with one febrile UTI. Remember, I told you any young infant, so any young infant less than 2 with high fever, you will be investigating for UTI. And you will then also be investigating for anatomic anomaly with ultrasound. So we already said who's indicated for an ultrasound. Children with 2 or more febrile UTIs. Children less than 2 with one febrile UTI. Children with a non-febrile UTI and risk factors such as poor growth, hypertension, or a family history of urological and renal disease. Children who do not respond to antibiotics. And then, remember, vesicoureteral reflux was a very, very common cause of UTIs. So, what will we investigate that with? You will investigate it with avoiding cystourethrogram, a VCUG, avoiding cystourethrogram, which is used to diagnose vesicoureteral reflux, in which urine flows backwards from the bladder towards the kidney during urination. To perform a VCUG, you basically inject a radio-opaque dye, radio-opaque contrast via a catheter through the urethra, and images are taken during urination. Perform a VCUG in patients with, again, 2 or more febrile UTIs, or children less than 2 with one febrile UTI, or an abnormal ultrasound. The DMSA scan, or the renal corticoscintigraphy with it, determines the functioning, and while voiding cystourethrogram will tell us the grade of the reflux, because there's grades 1 to 5, and if it's grade 5, you want to, for vesicoureteral reflux, you want to do surgery on them. You want to operate for patients with grade 5 vesicoureteral reflux. So the difference between avoiding serious cystourethrogram and a renal corticoscintigraphy is this will tell you the grade of the vesicoureteral reflux. Renal corticoscintigraphy might not. It doesn't, because it's kind of acute. It just shows you the flow. And actually it can also, no, it's not just acute. It also shows chronic renal scarring, and it's done following an ultrasound that suggests renal damage. So remember, you give an ultrasound to patients with 2 or more febrile UTIs, or children less than 2 years old with one febrile UTI, children with a non-febrile UTI or risk factors, like hypertension and family history, or children who do not respond to antibiotics. Voiding cystourethrogram must be done in all children with 2 or more febrile UTIs, even if they have a normal ultrasound, in order to assess for VER. Alright, thank you so much for watching. I hope this video helped and it covered the UTI in pediatric patients. Stay tuned for further videos in pediatric nephrology, and I'll make a playlist. Thank you so much, and please subscribe.